Good morning, all. I am Ankit Vyas, and along with Chhavi Maheshwari, I am representing Batch A under the guidance of Dr. Nahid Yasmin ma'am and Dr. Abhilasha Maharshi ma'am. So the case one is a patient named Daniel Reyes, age 45, working as carpenter, presented to the emergency department with sudden onset of discoloration in his left hand, described as pale and cool. He complains of arm fatigue and a dull ache in the upper arm after working overhead for prolonged periods. He has intermittent episodes of swelling in the left hand, especially after physical activity. Over the past week, the symptoms worsened significantly with episodes of tingling and cold sensations in the left hand. He also noticed small ulcerations on the tip of his fingers that have been slow to heal. On physical examination, the left hand is pale with visible cyanosis in the fingertips. Small superficial ulcerations are noted on the second and third fingertips and tenderness over the supraclavicular fossa on the left. CT angiography shows a narrowing of the subclavian artery with post-stenotic dilation and evidence of thrombus formation. So the presented case is of thoracic inlet syndrome, which is also called as thoracic outlet syndrome by clinicians because the arteries and nerves they pass through this and go to the upper limb. Thus, it is called thoracic outlet syndrome also. It occurs due to the compression of the lower trunk of brachial plexus and major vessels such as subclavian artery and vein. The boundaries of thoracic inlet are anteriorly, it is bounded by medial manubrium sterni, medially, laterally by the medial border of first rib, and posteriorly by the anterior border of the T1 vertebra, and it is directed downwards and anteriorly with an angle of 45 degree from T1 vertebra. So, sorry, the compression mainly occurs at the in the most of the cases it occurs at the this scalene triangle, which is through which the lower trunk of brachial plexus and subclavian artery passes, not the subclavian vein. So the main causes of thoracic inlet are first the anatomical variations, that is the formation of C7 formation of the cervical rib from the C7 vertebra, and second the trauma or injury which can be caused from an accident that can cause the fracture of the clavicle and thus can cause compression of these brachial plexus and this subclavian artery. Third is hypertrophy of the scalene anterior and middle scalene muscle, and fourth is the poor posture, and fifth is the pregnancy. There are mainly three sites of compression. First is in the scalene triangle between the anterior scalene muscle and the middle scalene muscle. Second is the costoclavicular space between the clavicle and the first rib, and third is the subcoracoid space near the coracoid process. This represents the most common case, which is the hypertrophy of the this scalene muscles, and it can cause the compression of the subclavian artery and compression of the this lower trunk of brachial plexus. There are three types of thoracic inlet syndrome. First is neurogenic, second is vascular, which has two types, arterial and venous. So in the neurogenic TOS, the main location is the interscalene triangle, which is bounded by the anterior scalene muscle, middle scalene muscle, and first rib. The structures passing are brachial plexus and subclavian artery, and this compression is mainly due to the scalene hypertrophy. Second is in the costoclavicular space, and here the arterial TOS occurs, and this costoclavicular space is bounded by the clavicle, first rib, and subclavius muscle, and the structures passing are subclavian vessels and lower trunk of brachial plexus, and this compression is mainly due to trauma such as fractured clavicle and whiplash injury. And Third is the subcoracoid space in which the venous TOS occurs, and it occurs beneath the pectoralis minor tendon, uh, which is near the subcoracoid space. The structure passing is subclavian vein, and the compression is due to the hyperabduction of the arm that can cause venous thrombosis. And the symptoms of thoracic inlet syndrome are mainly pain, tingling, numbness in the shoulder that radiate to the ulnar side, that is the medial side of the upper limb, because the lower trunk of brachial plexus C8 and T1 is getting compressed. The loss of sensation on ring and the ring finger and the little finger, ischemia, pallor, coldness, and feeble radial pulse due to the compression of the subclavian artery. And thank you. Now I would like to invite Chhavi Maheshwari.
Good morning, everyone. Myself, Chhavi Maheshwari. I will be talking about case number 2. A female named Sarah Thompson, age 32 years. Her chief complaints were intermittent right arm pain, numbness, and tingling, specifically in 4th and 5th fingers, worsened by overhead activities, example lifting hairs. Other symptoms were shoulder to finger radiation, grip weakness in the right hand, which was progressing over a few months. When doctor physically examined, he saw tenderness over a supraclavicular region in the right side, full range of motion in the neck and shoulder, but discomfort with overhead movements. Clinical investigations: cervical X-ray, bony projection from C7 transverse process, and Doppler ultrasound in subclavian artery compression during positional maneuvers was seen. Please refer to this X-ray. As you can see in this arrow, cervical rib is visible. So, first question was, what is the probable diagnosis for this case? It is cervical rib. Cervical rib is an anomaly. It is an extra bone in the cervical region that originates from the 7th cervical vertebra. As you can see, cervical rib is mentioned. Symptoms of the cervical rib: pain, neck or arm pain. It is due to the compression of the lower trunk of brachial plexus. Tingling or numbness in the hand or arm is also due to the compression of lower trunk of brachial plexus. Clawing of hand except thumb and index finger. It is due to the compression of lower trunk of brachial plexus. Weakness in hand and forearm is also due to the compression of lower trunk of brachial plexus. Cause of the brachial plexus is due to mutation in HOX gene, which is responsible for skeletal development during embryal stage. The second question which was asked to us was briefly describe the types of cervical ribs. Types of cervical ribs are type 1 or complete rib. It is a complete rib that reaches the first rib. Type 2 or incomplete rib, which one end does not attach to the first rib. Type 3 or fibrous cervical rib. It is an incomplete rib that attaches to the fibrous band. Type 4 or rudimental rib. It is a short bone that sticks out from the lowest vertebra in your cervical spine. You can see in the pictures also. Picture is given. In the first case, the rib is attached. Here you can see type 1 cervical rib. In type 2, you will see it is not attached. In type 3, it is fibers are attached to the first rib rather than a bone. And in type 4, it is just a small projection. Thank you.
A heartfelt thank you for your engaging and well-prepared presentation. Teachers, do we have any questions for them?
Call both the speakers. First speaker, you mentioned about the interscalene triangle, and you said that it is neurogenic. if both subclavian artery and the brachial plexus lower trunk is passing, then why is it neurogenic and not vascular?
It is in the most of the cases it is neurogenic. It is vascular also, arterial, but not that venous. It is not venous thoracic outlet syndrome because the subclavian vein does not pass through it.
Yeah, but the subclavian artery does. So, because that was new to me, it's something I also want to clarify, that is it written in the book it's neurogenic because the subclavian artery also passes, so the compression of that can lead to the feeble pulse and all that. Okay. And for your presentation, second speaker, you talked about all the symptoms, but you said the lower trunk of the brachial plexus. Can you just elaborate what is lower trunk and what symptoms, which nerve is it affected, and how is it affecting, which side of the upper limb is affected and why? Can you elaborate on it?
So, lower trunk of brachial plexus is C8 and T1. The nerve which is involved is ulnar nerve, and
so which part does it supply mainly?
Upper limb.
Which part of the upper limb?
Medial part.
Yeah, along the medial margin. So that need to be specified further. Okay. Just lower trunk is a very broad term. Lower trunk, upper trunk. Good, nice presentation. You can call the group teacher if they wish to. If anyone wants to sum up, you can.
Everything is nicely explained in this presentation. We should know what are the structures passing through the thoracic outlet or thoracic inlet. So one question I have for you, what is anatomically, what are the boundaries of thoracic outlet? And clinically, what is thoracic outlet? Anyone?
Close the door.
Because we are calling it thoracic inlet syndrome also and thoracic outlet syndrome. So anyone thought of it, why it is inlet also and outlet also? Anyone? Why both the terms simultaneously? Yes, Keshav? Due to phrenic nerve. Anyone else? Because anatomically you have read that there is a thoracic inlet and then on the lower part near the diaphragm there is thoracic outlet. So between them there is thoracic cavity. So basically it is clinically all the major vessels of they are passing through this thoracic inlet, and so clinically thoracic inlet is referred to as thoracic outlet. Anatomically the lower part of thoracic cavity we call it as thoracic outlet. But so on and so forth, when you go to the higher or the clinical side, the inlet and outlet are used simultaneously, and that is on the upper part. The boundaries have been discussed. And as for your question, sir, yes, you are very much right that there can be vascular compression also in the interscalene triangle. In majority of the cases, like when we study in the most number of the cases, there were neurogenic cases that were reported, but there can be vascular compression and the feeble pulse can be felt. So thank you.
Thank you, ma'am. Next from batch B, we have Manisha Chaudhary and Hiti Bhandari. So, how to do? How to change the PDF? I'm sorry.
It's coming.
Good morning to one and all. My name is Manisha Chaudhary and I'll be representing batch B under the guidance of Dr. Rati ma'am, Lieutenant Colonel Sunil sir and Dr. Runjun ma'am. Today I'll be discussing a clinical case on rib fracture. Do you know that in elderly, each additional rib fracture increases the chances of motility by 19% and chances of pneumonia by 27%. Now, why I'm telling you this? Because my today's objective is to emphasize and highlight the importance of proper management and diagnosis of rib fracture. Now, with that background, let's proceed to the case. A 35-year-old man was admitted to the hospital after an automobile accident and was presented with severe pain in the right chest wall. After examining the X-ray, he was presented that he has a multiple rib fractures. Here you can see. Here you can clearly see that he has multiple rib fractures. Now, during the chest wall examination, the doctor observed that he has paradoxial chest movement as seen is the flail chest and bruising, swelling and deformity over the chest wall. While the doctor can also palpate the chest and found that the fractured bones and rubbing against each other known as the palpable crepitus and tenderness and pain on palpation. In rib fracture, a patient usually presents with a history of trauma such as car accidents and sports injury, describes the pain as sharp, pointed, knife-like. During physical examination, pleuritic chest pain may be present and can be worsened according to position, and tenderness can be present on palpation. Now with that, let's see what actually is a rib fracture. Rib fracture involves a break and crack in one or more ribs due to stress or trauma. Now, the most liable part of the rib, the most liable part where the rib fracture is the costal angle. Here, you can appreciate in this image that this is the most posterior part of the rib. The rib curve costal angle is an area where the rib curves most significantly. So it's the most weakest and the most liable part of the rib where the rib fractures. Rib fractures are very, very painful, especially during breathing. A clinical condition known as pleuritic chest pain. What exactly happens in pleuritic chest pain is when you do inspiration or expiration, you will feel more pain as compared to when you will hold your breathing. So, when rib fracture can cause coughing and sneezing, which will further increase the chest pain. As a response, the patient will decrease his breathing in the fear of pain. His lungs won't fill with adequate air, lead to the decreased tidal volume and will eventually lead to restrictive lung disease. Now, what is a flail chest? Flail chest occurs when multiple rib fractures. A part of chest wall is separated from the rest of the chest wall, which moves freely and causes paradoxial movement. Now, what is paradoxial movement? It is the opposite movement of the chest wall, which occurs normally in the breathing. In inspiration, instead of forward movement of the chest wall, the ribs flail segments move inward, and in expiration, instead of moving inward, they move outward. So, they decreases the ventilation and decreases the gaseous exchange. Treatment of rib fracture. Usually, the treatment is not required as they heal on their own within a month or two. Surgery is required in severe cases like injury of internal organs, malunion and non-union. I forgot to add that in normal cases, you can do proper rest, icing and breathing exercise which will help in proper management of the rib fracture. In surgery, we fix the chest segment by hooks and wires so that it cannot move. Here, in this picture, metal plates and screws are used to fix the broken rib fragments. The bony landmark for the counting of ribs. The sternal angle or the angle of Louis is the key bony landmark used for the rib counting. It is a junction between the manubrium and the body of sternum. Here the articulation of the second rib takes place. How do we feel the sternal angle? In the front of the chest, you will go and feel the jugular notch. From there, you will move 5 centimeter downwards and feel a ridge that will indicate the sternal angle. And here, articulation of second rib will take place. Now, from here, how we are going to count the ribs? Are we going to count the ribs vertically downward? The answer is no, because we can. Not all ribs are Not all ribs are sterno. I'm sorry. Not all ribs are coming forward to address sternum. So we will go obliquely and will use the mid-axillary line to count the ribs and will approach the lower ends of the ribs. In this, we can appreciate how we are going to count the ribs in the X-ray. You have to understand that for counting of ribs in X-ray, this is the posterior part of the rib which is visible. So you have to follow the course over here to see the articulation of the ribs. So mostly what we are seeing is the posterior of the ribs which is visible in this. The least commonly fractured ribs are the upper two ribs, first and second, protected by the clavicle, especially the first rib, and the lower two ribs, 11th and 12th, are the floating ribs which are freely mobile, so they are least commonly fractured ribs. In infants, ribs are elastic, less likely to be fractured. In elders, rib fracture can be deadly. Back to the statistic which I told you in the starting of my presentation, why rib fractures are deadly in elders. As the pain increases in rib fracture, the elders or the patient decrease his deep breathing and resort to shallow breathing, which will further cause hyperventilation, led to the atelectasis and pneumonia. What is atelectasis? Is the alveoli lost air, and in pneumonia, the alveoli is filled with fluid. Structures prone to injury in rib fracture. First is the neurovascular bundle. Location is in the costal groove, which is on the inferior border of the ribs. Here you can see. This is where the neurovascular bundle is present. So injury to the intercostal nerve, severely localized pain and altered sensation. And intercostal vessel injury can lead to hemothorax, that is the blood filled in the pleural cavity. One thing, on the upper border of the ribs, we can do thoracocentrosis. Lungs and pleura are the other organs which can be damaged, can cause pneumothorax, air filled in the pleural space, causing lungs collapse, leading to the respiratory distress. In this X-ray, we can see that this lung, mostly the right lung, is filled with air. Air is of lesser density, so it is visible as dark black in this. And hemothorax, blood accumulation in pleural space, may compress the lungs and impair breathing. Abdominal organs, liver, spleen and kidney can also be damaged. Right fracture may damage the liver, left fracture may damage the spleen, and the fracture of 11th and 12th rib may damage the kidney. Major vessels which can be damaged. In the first rib fracture, here we can see that the brachial plexus, subclavian artery, subclavian vein which passes on the superior surface of the first rib can get damaged, and the greater vessels. Thank you.
Good morning, respected professors, seniors, and my dear colleagues.
I am Iti Bhandari and today I will be presenting the clinical case second from batch B under the guidance of Lieutenant Colonel Dr. Shekhawat sir, Dr. Renuka Seni ma'am and Dr. Rati Tandon ma'am. Let's begin with the case details. A 4-year-old boy was brought to the emergency department with the following complaints. While eating peanuts, he suddenly started choking and coughing. This episode lasted for a few minutes and was followed by difficulty in breathing and wheezing. So these symptoms indicate foreign body aspiration as the boy was eating peanuts when this episode happened. To confirm the diagnosis, we are also given an X-ray. As you can see in this X-ray, there is a presence of foreign body. A radio-opaque object is visible and this location corresponds to the anatomical part of the right principal bronchus. So this confirms our foreign body aspiration. There is also opacity in the lower portion of the lung, which will be discussed later. To understand this condition better, we will now see how the bifurcation of trachea occurs. Trachea bifurcates at the level of the lower border of the fourth thoracic vertebra at the sternal angle, which can be felt as the ridge 5 cm below the jugular notch. This location also marks the division into the left and right bronchus. Now let's go into the detail of our case. Foreign body aspiration into the right principal bronchus. It is a medical emergency when a foreign object is inhaled into the respiratory tract. It obstructs the airway. The right principal bronchus is the most common site for this aspiration due to its anatomical characteristics. Now let's see the anatomical basis of this condition. The right principal bronchus in comparison with the left bronchus is shorter. It is 2.5 cm in length, which is almost half the length of the left principal bronchus. It is more wider, vertical and in line with the trachea at an angle of 25 degrees, whereas the left principal bronchus is in line at 45 degrees. As you can see in this diagram, this is less angle and more straighter path for the object to enter into the respiratory tract, whereas the left bronchus is in 45 degrees angle. The left principal bronchus has certain features which makes it less possible for foreign body aspiration. It is longer, narrower, more horizontal and at an angle of 45 degrees. As you can see here, the left bronchus is very narrow as compared to the left bronchus. So foreign bodies tend to go into the right principal bronchus. Now that we have discussed the anatomical basis, let us see its management. The foreign body aspiration is a very emergency medical condition and it requires immediate intervention. So the major first aid method for this condition is the Heimlich maneuver. The Heimlich maneuver is performed to expel the foreign body from the airways. The procedure to perform is to stand behind the patient. We should wrap our arms around the patient, make a fist with one hand and place the other hand to grasp it tightly. The thumb portion of the fist should be below the rib cage or 2 inches above the belly button. We should make a quick upward and inward movement and we should perform this procedure till the foreign body is expelled. If the Heimlich maneuver fails, we should provide assistance in coughing and we should also provide oxygen supplementation to the patient. The definitive treatment of this condition is bronchoscopy. Bronchoscopy allows direct examination of the airways via a specialized tool known as the bronchoscope. The bronchoscope is inserted through the nose or the mouth after sedation to reach the airways and the foreign body can be removed via the forceps or suction. Foreign bodies can be removed by 2 bronchoscopy methods, that is rigid bronchoscopy and flexible bronchoscopy. The rigid bronchoscopy for foreign body removal is used in children It also provides better airway control and allows simultaneous ventilation. And it is also effective for larger, sharper objects. But the flexible bronchoscopy is used for distal airway foreign bodies, that is in more lower respiratory tract. It also has a risk of pushing the foreign bodies deeper, and it is also not effective for larger objects. Another important finding that we can see in this X-ray is the pleural effusion. As you can see, this is opacity in the lower right lung, and the right costophrenic angle is obliterated. This indicates pleural effusion in the right lung. Pleural effusion is the extensive accumulation of fluid in the pleural cavity, also called as pleural effusion. It occurs due to inflammation of the pleura and leads to decreased expansion of the lung and dullness on percussion on the effusion site. The definitive procedure for treatment of pleural effusion is pleural tapping, also known as thoracocentesis. In this, excess fluid is aspirated from the pleural cavity. The pleural fluid can be located by percussion or real-time ultrasound. The needle is inserted on the 8th or 9th intercostal space in the mid-axillary line to ensure that the needle does not puncture the lungs. It is also done on the 8th or 9th intercostal space so that it does not injure the intercostal vessels and nerves. The structures pierced during a pleural tap is the skin, superficial fascia, the serratus anterior muscles, the intercostal muscles like the external intercostals, internal intercostals, and innermost intercostals. Then it can be pierced the endothoracic fascia, the parietal pleura, and the pleural cavity. Thank you.
Your hard work and clear articulation of complex concepts were truly commendable. Now I would like to invite Batch B mentors to sum up.
Okay, there are two corrections in both presentations. First, in the this first presentation, इसमें इन्होंने बोला कि she said that under the guidance of Dr. Renuka Saini, that is Dr. Unjul, that is Dr. Renuka Saini. Then in second, every student should learn that who is the senior. Okay, when you write the name of faculties, they should be in the seniority. So in second PPT, the Dr. Ratik Tandon should be above. Okay, now I want to add or ask the interns, what is this gas, this black shadow under this diaphragm door? Anyone? Is it normal or is it abnormal? Is it normal? Yes. So this is the gas in the fundus of the stomach. If it is on the right side, then it is normal or abnormal? Abnormal. Why? Yes, there are chances of intestinal perforation. Then because of that, pneumoperitoneum will be there. So anyone who or see, anyone seeing this X-ray, whenever you see air under diaphragm on the left, it may be normal. On the right side, it will be abnormal. So you should go for the clinical evaluation that patient. Thank you.
Can we have the speakers also here? Both your presentations were very good, especially the PPT was so well made. But very few written part and very, very good PPT. And even the presentation was good. Hiti, what's the normal pleural fluid you have amount? Around? 5 to 10 ml. Okay, approximately, yeah, 15, yeah, okay, you can say. And when do you call it pleural effusion?
More than 20 ml.
Generally, it is like if it's more than 250 to 300 ml, then you see it in the X-ray. With smile, pleural effusion won't be shown. Uh, what is the first sign? Where do you have the pleural effusion in the X-ray and why?
Sir, in the costodiaphragmatic recess.
Why is it the costodiaphragmatic? What are the other recesses? Can you just elaborate? एक costovertebral recess भी है, एक costodiaphragmatic भी है. तो why is it costodiaphragmatic recess?
Sir, the pleura, visceral and parietal pleura, the space, the pleural cavity is there.
Anyone from the students? Yes, as Rakshit said, the most dependent part of the pleural cavity. Okay, so जहाँ सबसे dependent part रहेगा वहीं पर accumulate करेगा fluid. Okay, good presentation, good. But Dr. Prabjot would be asking a few things.
So first of all, wonderful presentation. Though she was given a case of foreign body bronchus, but in the X-ray, pleural effusion was there, so she did justice to that also. पूरा आपने explain किया. And one more thing, you have added the rigid bronchoscopy and the flexible bronchoscopy. वहाँ तक भी मतलब you have tried to explain. Just one question, if the foreign body bronchus, if it is entering into the lung, can you tell me the most common bronchopulmonary segment which can be involved by this? It will be lodged in which, if it is going to the lung, it will be involved by that. The foreign body will be lodged in which bronchopulmonary segment?
This is a PG question for all of you.
Huh?
If they don't answer, you should be answering. Which is the commonest site for
Yeah.
lodging of the
Foreign body.
Bronchopulmonary segment ma'am पूछ रही हैं.
Can you name the lobe? First name the lobe. Will it be, how many lobes are there in the right lung? 3 lobes. So there is upper lobe, middle lobe and the lower lobe. So where it will be going? It will be going to the lower lobe. And which bronchopulmonary segment? 6. She's saying 6. So anybody else, the name, according to the names of the segment, there is apical segment, there are basal segments. So which segment? Posterior basal segment. Most commonly it is the posterior basal segment. It goes to that.
Was it posterior or was it apical of the lower lobe? I have a small confusion over here. We'll just check it out, okay? Yeah, but उसमें basal maybe, I think it's the apical, the superior part of the. We'll check it. I might be wrong though. Okay, we'll move on to the next speaker.
Moving on, from batch C, we have Moni Singhal and Priyal Chaudhary.
Change आप लोग सीख लिया कीजिए. Teachers से मत उम्मीद कीजिए कि the teachers will come and do it for you. Students should be doing it. Students should be doing it for the teachers. It should be the other way around. Colonel Shekhawat is too kind.
Good morning everyone. I am Priyal Chaudhary from batch C and I along with Moni Singhal are going to talk about few clinical cases that were assigned to us on the topic of thorax. And this whole activity was under the guidance of Dr. Manali, Dr. Runjun ma'am, Dr. Rishika ma'am and Dr. Ashima ma'am. So there were 2 cases that were assigned to us and the case 1 as you can see on the slide was a 48-year-old man who visited the OPT with complaints of pain on right side of chest, difficulty in breathing, fever and dry cough. He also gives history of pain radiating to the tip of shoulder and anterior abdominal wall. On examination, a dull note along 7th to 10th intercostal spaces with absence of breath sound on right side was seen. On auscultation, X-ray was done which showed CP angle obliteration. The following procedure was done to relieve the symptoms. So this was the case that was assigned to us. And the first question is, what is the probable diagnosis? So it is a case of pleural effusion. What is pleural effusion? It is the excessive accumulation of fluid in pleural cavity. There are two layers of the pleura, the visceral and the parietal pleura, and the space between them is known as pleural cavity. And the excessive accumulation of fluid in that cavity is known as pleural effusion. So normally 10 to 15 ml of serous, acellular and clear fluid lubricates the two surfaces of the pleura. But due to excessive accumulation of fluid, the pleural effusion occurs. So what are the symptoms of pleural effusion? The symptoms of pleural effusion may include dyspnea, that is difficulty in breathing. It occurs due to compression of lungs and caudal displacement of diaphragm. Also, pleuritic chest pain can be present, which indicates inflammation of parietal pleura, and dry and non-productive cough is also seen. But with presence of mere symptoms, we cannot rule out that it is pleural effusion. So what is the probable diagnosis of pleural effusion? The pleural effusion can be diagnosed by chest X-ray and ultrasound. However, very small pleural effusions may not be visible on chest X-ray but can be detected on ultrasound. However, the chest X-ray findings of large effusion include complete opacification of lungs, mediastinal shift due to excessive intrapulmonary pressure, and tracheal deviation away from the effusion, that is on the healthy side. So as you can see in the image, the CP, let's see what is the CP angle. So the angle between the rib cage and the diaphragm is known as CP angle, and in normal cases a very sharp and prominent shadow is seen for the CP angle, but due to pleural effusion the CP angle becomes rounded and a blunted CP angle is seen. Next question is, give anatomical basis of radiating pain. So the parietal pleura is divided into four parts, that is the cervical pleura, the costal pleura, the diaphragmatic pleura and the mediastinal pleura. The central part of diaphragmatic pleura is innervated by the phrenic nerve, which has root values C3, C4, C5. The supraclavicular nerve, which has the similar root values of C3 and C4, also supply the skin of the shoulder tip. Due to similar spinal roots, pain of central part of diaphragm is referred to the shoulder tip. Also, the costal and peripheral part of diaphragmatic pleura is supplied by the intercostal nerves, which has root values of T1 to T11, and the last 5 intercostal nerves, that is from T7 to T11, also innervate the skin of anterior abdominal wall. So the pain from the diseased pleura radiates to the anterior abdominal wall, and the patient comes with the complaint of abdominal pain. Now the next question that we were asked are, name the recesses of the pleura and nerve supply of pleura. So let's first see what are pleural recesses. Pleural recesses are extended part of pleural cavity beyond the lungs, which serve as reserve spaces for pleural cavity, and they are essential for expansion of lungs. There are two types of pleural recesses, that are the right and left costodiaphragmatic recess and the right and left costomediastinal recess. The costodiaphragmatic recess is a potential space located at the junction of costal and diaphragmatic pleura, as you can see in the diagram. It is marked by the yellow circle, and it is the largest of the pleural recess, and is important because it is a common site for pleural effusions to accumulate, because it is the most dependent part of the thorax. The next recess is the costomediastinal recess. It is a potential space located at the junction of costal and mediastinal pleura. It is smaller than the costodiaphragmatic recess and is located anteriorly behind the sternum. Also, the point to be noted is the left costomediastinal recess is larger than the right costomediastinal recess due to presence of cardiac notch on the left lung. Now let's see the nerve supply of the pleura. So there are two layers of the pleura, that is the parietal pleura and the visceral pleura. And as we just saw, the parietal pleura is supplied by the intercostal nerves and the phrenic nerve, whereas the visceral pleura has autonomic sympathetic supplies from the autonomic nervous system. So the parietal pleura is innervated by the somatic nerves and thus it is sensitive to pain, whereas visceral pleura has autonomic supply and it is not sensitive to pain, stimulus like pain and touch. Now the next question that we were asked is which procedure is shown in the image. So as you can see in the image, the process is thoracentesis or pleural tapping. It is a procedure by which excessive fluid is aspirated from the pleural cavity. And from the outside, this excessive fluid is located by percussion or real-time ultrasound.
It should be thoracentesis. Thoraco, not thora,
it's thoracentesis everywhere, sir.
You see it again.
Okay. So the question arises, what is the site at which thoracentesis is done? So most importantly, the patient is supposed to sit in the upright position. Then needle is inserted in the 8th or 9th intercostal space in mid-axillary line. Actually, the space was 6th intercostal space, but according to latest guidelines, it's 8th or 9th intercostal space in mid-axillary line during expiration to avoid inferior border of the lung. The extent of the lung is till the level of T8, so we choose the 8th or 9th intercostal space. Then the needle is inserted through the lower part of the space along the upper border of rib to avoid injury to any neurovascular bundle, that is the intercostal vein, artery or nerve. So as the needle passes the skin to reach the pleural cavity, there are certain structures that it pierces. So the needle passes in succession through the skin, the superficial fascia, the serratus anterior muscle, intercostal muscles, endothoracic fascia, parietal pleura, and finally the pleural cavity. Now here is a small video to better understand the process of thoracentesis.
साउंड आपको प्रोवाइड करना है कर्नल शेखावत का.
I will explain it myself. So first, the pleural fluid is located from the real-time ultrasound or percussion. Then a needle is inserted, as you can see. So a needle is inserted to know the exact location of the pleural fluid. A syringe is inserted basically. Then when we finally locate the exact location, now we will insert a needle to aspire the accumulated fluid. So with this, I end my first case. Now Monish will continue with the second case. Thank you.
Good morning, my respected teachers, respected seniors, and my fellow classmates. Uh, Me, along with Priyal Chaudhary, my name is first of all, my name is Monish, and me, along with Priyal Chaudhary, are presenters from Batch C. So, the case given to me was a 40 years old woman was brought to the emergency ward following a gunshot injury to the left thoracic area. She presented with acute respiratory distress. Examination revealed hyperresonance and absence of breath sound on the left side. On radiological examination, a mediastinal shift was seen. So, first question was, what is the probable diagnosis? As we can, uh, as we can see that there is hyperlucency on the affected side. Hyperlucency is due to the accumulation of air, as it is less dense than other like fluid or blood. Also, we can see that there is a mediastinal, this is the highlighted part. We can see that there is a mediastinal shift, which is indicated by the shift of trachea. The shift is to the opposite side of the affected, opposite of the affected side. Also, on percussion, there is hyperresonance and absence of breath sound on the left side. As we can see that there is a lung collapse, there is a obliteration of costophrenic and cardiophrenic angles, so there is an overall lung collapse. So, which is a characteristic of tension pneumothorax. So, the probable diagnosis is the cases of tension pneumothorax. So, what is a pneumothorax? So, accumulation of air in the pleural cavity is pneumothorax. Or other than air, fluid known as hydrothorax, blood known as hemothorax, and rarely lymph known as chylothorax can also accumulate in this space. Sometimes what happens that the layer of the pleura and the lung form a clothing, merge and form a clothing-like structure which forms a ball, which does, because of which the air enters inside the lung during inspiration, but it cannot escape. This will lead to the cancellation of negative intrapleural pressure, which will lead to lung collapse. So, what are the types of pneumothorax? Basically, there are three types of pneumothorax: open pneumothorax or traumatic pneumothorax, closed pneumothorax or spontaneous pneumothorax, and the third is a complication of both of these known as tension pneumothorax. So, in open pneumothorax or traumatic pneumothorax, it may be due to both penetrating and non-penetrating causes. It is usually treated by thoracostomy and also in open pneumothorax, laterogenic pneumothorax is common, which occurs clinically due to transthoracic centesis and thoracocentesis. Second one is closed pneumothorax or spontaneous pneumothorax. So closed pneumothorax is due to without antecedent trauma to the thoracic wall. It can be of two types: primary spontaneous and secondary spontaneous. Primary spontaneous is generally due to rupture of apical pleural breast, and it is almost exclusively common in smokers. Also, it can be recurrence is common in primary spontaneous pneumothorax. So, thoracostomy is done with pleural abrasions. Secondary spontaneous pneumothorax is due to underlying lung disease, which can be obstructive, which is mainly obstructive, chronic obstructive pulmonary diseases. It is more dangerous than primary spontaneous pneumothorax because due to less lung reserve in obstructive disease patients. The treatment is same as primary spontaneous pneumothorax. The third one is tension pneumothorax. Tension pneumothorax is a complication of both open and closed pneumothorax. And tension pneumothorax, a valve-like effect occurs, which I discussed previously, due to which there is collapse of lung leading to hypoventilation and thereby decreasing the cardiac output, and also a mediastinal shift is seen, and thus it creates an emergency situation. So, the second question is, what is the extent of pleura? So, a pleura is a double-layered membrane surrounding the lungs, which is comprised of two layers, the visceral pleura and the parietal pleura. Visceral pleura lines the lungs, and the parietal pleura is in contact with the thoracic wall, and they both have a pleural fluid in between them, which reduces friction, and thereby allowing the easy movement of lungs during respiration. So, here we will discuss the extent of pleura. So, first of all, parietal pleura has four parts. Cervical, the cervical part, the diaphragmatic part lining the mediastinal part lining the mediastinal region, the diaphragmatic part in contact with the diaphragm, and the costal part in contact with the ribs. So, first of all, in the part in contact with the mediastinal is also called the costomediastinal line of pleural reflection. In the mediastinal line of pleural reflection, and it is present in the mid-sternal angle. It starts from the sternoclavicular joint till the extend to the midpoint of sternal angle and till the midpoint of cephosternal joint. Then in diaphragmatic line of pleural reflection, it is present at the level of 8th rib in the midclavicular line, at the level of 10th rib in the mid-axillary line, and at the level of 12th rib posteriorly. There is a difference in the costomediastinal line of reflection on the right side and the left side due to presence of heart. On the left side, we can see that it extends till the midpoint of sternal angle. Then it at the level of 4th rib. It makes an arc and goes towards the left border of the sternum due to provide space for heart. Rest all the extent is same. Also for the visceral pleura lines the lungs, so its extent is same as the lungs. For the extent of lungs is same around the most of the part, but is different along the costodiaphragmatic part. In the costodiaphragmatic part, the extent of lung is T6 in the midclavicular line, T8 in the mid-axillary line, and T10 posteriorly. So, what is mediastinal shift? Mediastinal shift is a condition where the central structures of the chest, including the heart, trachea, esophagus, and major blood vessels, are displaced from the normal position toward one side of the chest. The shift may be towards the same side as the affected side, known as ipsilateral, or to the opposite side, known as contralateral shift. Ipsilateral shift is common in lung collapse and pulmonary fibrosis, and contralateral shift is seen in tension pneumothorax and when there is large tumors or masses. So, what is the anatomical basis of respiratory distress in patients? There can be various causes for respiratory distress, but in tension pneumothorax, the main causes are loss of negative pleural pressure. So, when the air accumulates in the lung, air accumulates in the pleural cavity, there is cancellation of the negative pleural pressure, which is preventing the lung from collapsing. Actually, the lung has a tendency to collapse, and negative pleural pressure prevents that. So, when there is loss of negative pleural pressure, there will be collapse of lung, and which lung collapse will in turn lead to hyperventilation due to reduced surface area. Also in tension pneumothorax, we have seen a mediastinal shift which will lead to compression of the contralateral lung and the major blood vessels, which will again lead to reduced blood pressure. Also, there is impaired diaphragmatic function due to accumulation of air, which can limit diaphragmatic movement, and also there is ventilation perfusion mismatch. There is a video of anatomy and acute respiratory distress. As we can see, the patient is having difficulty in breathing. It is trying to voluntarily move the chest, but due to collapse of lung, he is not able to breathe properly. And we can see there is nasal flaring, suprasternal retraction due to soft tissues present behind the sternum. Also, there is voluntary movement of intercostal muscles. As the patient is not able to breathe properly, he is also using his accessory muscles. Also, there is cyanosis in the patient due to more reduced hemoglobin in the blood. Also, due to hypoventilation, there will be reduced cardiac output, and this will lead to reduced blood pressure. Thank you. And special thanks to Rachit and Per for helping me out in all of this.
One thing I wanted to ask you, and also the entire batch after you, including the seniors sitting over here, what are the sites where the pleura is not covered by thoracic wall? Because you need to be very careful that when you are doing a intra-abdominal operation, okay, that you don't enter into the pleura and the thoracic cavity. So what are the sites? I'm repeating, what are the sites where the pleura is not covered by thoracic wall? And there are 4 sites. 3 is in the costal margin. I'm giving you a hint, along the costal margin, and 1 is a different site.
Sir, along the cervical region, where the pleura extends, there will be.
Very good. 1 is the apical region, okay, where you have the suprapleural membrane or the Simpson's fascia. That's one region where it's not covered. Very, very good.
The diaphragmatic part, because it is covered by the diaphragm and ribs or on the.
You have to be more specific. Diaphragmatic part is like, not the entire part is not covered. It's only a small part. Tarushi, where are you? Tarushi Sharma? Stand up, stand up. Suhani Bansal. After that, I'll come to the rest of the batch. Suhani Bansal. Can you answer, any one of you? Anyone from the batch? There are Chesta and all the JRs over here. And all the elective people, anyone remember? You have the costovertebral angle, left and right. Pehla do to ye ho gaye. Okay. Then there is a costoxiphoid angle on the right side only, not left. So these 3 sides, and 4th is the angle, is the costal, cervical part of the pleura. Another thing I wanted to ask you is, you talked about paracentesis and where to do it, but when you are putting an intercostal tube, what is the site for the introduction of that tube, intercostal tube, for drainage?
8 to 10 intercostal space.
Sorry?
8 to 10 intercostal space.
No, that was for the thoracentesis. That was a needle you are putting, okay? But when you are doing like in a tension pneumothorax, you do it in the second intercostal space. But when you have to drain fluid out, what is that space? Kahan par karoge? Anyone? Yeah. Very good. This is just anterior to the mid-axillary line. It's anterior to the mid-axillary line, 4th and 5th intercostal space. She was exactly right, 5th or 4th, okay, both are correct. Okay, that is one area where you would do it, and there is actually a triangle that is formed. Safety triangle, yes. Can anyone define that triangle? It is between the pectoralis major, latissimus dorsi, and a horizontal line along the nipple, okay. Those 3 points, they make a safety triangle, and in the fifth intercostal space, as Dr. Cheshta said, in the fifth intercostal space, yeah, just in front of the mid-axillary line, that is where you do it. In pneumothorax, when the air is going in, why is it not coming out because of expiration?
Due to the absence of negative intrapulmonary pressure. So there should be the negative pressure to release the air, and it is absent cause direct.
Negative pressure is one thing, another is the muscles which is piercing is acting as a valve. Okay, so that's not letting it. Very good presentation, okay. These are the take home messages. कहाँ पर करना है आपको, कहाँ ट्यूब डालना है, कहाँ पर आपको थोरैकोसिंथेसिस करना है. प्लीज टेक इट बैक, अदरवाइज इन सेमिनार्स का कोई भी फायदा नहीं है अगर ये सब सीख के नहीं जाएंगे. जस्ट टेक द इम्पोर्टेंट पॉइंट्स.
The visual aids that you incorporated were a nice and fantastic idea. Lastly, from batch D, we have Vanisha Goyal and Yashim.
Good morning everyone, my name is Yashashwini and I am the presenter of batch D and my topic is Pancreas tumor. So this was the case given to us which says a 75-year-old male chain smoker visited the general physician with the complaints of extreme tiredness, weight loss and blood-stained sputum. The patient presented with severe right shoulder pain accompanied by weakness in the right hand and atrophy of the thenar muscles. He also reported inability to open the right eye. On clinical examination, the doctor found partial ptosis, constriction of the pupil in his right eye and anhidrosis on right face. The chest X-ray revealed a radio-opaque shadow in the apical region of the right lung. This was the X-ray given to us, and these were the questions in which we were supposed to tell the probable diagnosis, area of the lung which is involved, anatomical relation, structures involved, anatomical basis of the symptoms. So the probable diagnosis of the case given to us is Pancreas tumor. Pancreas tumor is also known as superior sulcus tumor. It is developed on the apex of the lung, mainly on the posterior side. ये जो इमेज आप देख रहे हैं, ये डॉक्टर हेनरी पैनकॉस्ट हैं. इन्होंने ईयर 1934 में पैनकॉस्ट ट्यूमर को डिस्कवर किया था और ये अमेरिका के पहले रेडियोलॉजिस्ट थे जिन्होंने ऐसा किया था. In this is a plain X-ray of chest region, PA view. Here you can see of a patient having Pancreas tumor in the right lung. Here you can see on the right lung there is an radio-opaque shadow, whereas the left lung appears black and lucent. Right lung, apex of the right lung indicates Pancreas tumor. जब हम अपेक्स की बात करते हैं तो हमें उसका एग्जैक्ट रिलेशन और आसपास के स्ट्रक्चर्स का पता होना ज़रूरी है ताकि हम उसका ट्रीटमेंट और क्लिनिकल सिम्टम्स को और अच्छे से समझ पाएं. सो द अपेक्स रीजन इज प्रेजेंट 3 cm superior to the anatomical border of the first rib and 2 to 3 cm superior medial one-third of the clavicle. On the anterior side it includes cutaneous anterior, internal thoracic artery and subclavian artery. On the posterior side it includes superior intercostal artery, posterior intercostal vein, ventral ramus of the first thoracic nerve and sympathetic chain stellate ganglion. Now the question arises, what is stellate ganglion? As we know, on the posterior side of our body there is a vertebral column and a sympathetic chain runs along it on both the sides. It is made up of many ganglions and stellate ganglion is also one of them. Due to the compression of stellate ganglion, Horner syndromes occur. And you can also see that C8 and T1 root values of the brachial plexus are also getting affected, due to which atrophy of thenar and hypothenar muscles occur, because C8 and T1 root values are common in ulnar and median nerve, which supplies the thenar and hypothenar muscles of our hands. Whenever a tumor expands in our body, so it will going to compress the nearby structures, due to which several anatomical symptoms occur in our body. So, for example, we can see first, due to the compression of stellate ganglion, Horner syndrome occurs, जिसके symptoms हैं anhidrosis, meiosis and ptosis. Second, due to the compression of brachial plexus, we can see shoulder pain. Third, due to the compression of recurrent laryngeal nerve, जो कि larynx को supply करती है, we can see hoarseness in voice. Fourth, due to involvement of C8 and T1, we can see atrophy of thenar and hypothenar muscles. Here in this slide, you can see on the second diagram, there the highlighted area represent the affected area where weakness, pain, atrophy, and paresthesia of the muscles occur along the ulnar nerve. And sometimes the pain can also radiate to the chest region and to the scapular region, as you can see in the third slide. You can see the scapular region is involved, and in the second you can see the chest region with light green color. This is how exactly it looks like when wasting of thenar and hypothenar muscles. You can see a shrinkage in the thenar and hypothenar muscles. Now the tumor, due to the metastasis of the tumor, it can also spread to the anterior structures of the apex of the lung, which includes, for example, subclavian artery. Subclavian artery जो कि आगे जाके axillary artery और brachial artery और radial artery बनाती है. अगर subclavian artery compress होगी तो radial pulse और brachial pulse हमें diminish सुनाई देंगी. और अगर phrenic nerve affect होगी तो जो कि हमारे डायफ्राम को सप्लाई करती है, तो पैरालिसिस ऑफ डायफ्राम हमें देखने को मिलेगा. Now Horner syndrome. As I told you that due to the compression of stellate ganglion, Horner syndrome occurs. Now why it happens? जो गैंग्लियंस हैं हमारी बॉडी में, उनको सिंपैथेटिक फाइबर सप्लाई करते हैं, जो कि लेटरल हॉर्न ऑफ स्पाइनल कॉर्ड से अराइज होते हैं. सिंपैथेटिक फाइबर्स का हमारी बॉडी में क्या काम होता है? वो प्यूपिल को डायलेट कराते हैं, आईलिड्स को रेस कराते हैं और स्वेट प्रोड्यूस करते हैं. अगर ये फाइबर्स अफेक्ट हो जाएंगे तो ये काम नहीं हो पाएगा, जिसकी वजह से डायलेट प्यूपिल नहीं हो पाएगी तो कॉन्स्ट्रिक्टेड प्यूपिल देखने को मिलेगी, जिसको मायोसिस बोलते हैं. आईलिड्स रेज नहीं हो पाएंगी तो ड्रूपी आईलिड्स हो जाएंगी, जिसको टोसिस बोलते हैं. और स्वेट प्रोड्यूस नहीं हो पाएगा तो उसको अनहाइड्रोसिस बोलते हैं. Here in this video, you can see a patient of Pancoast tumor, and he is having symptoms of he is having Horner syndrome. In his left eye, you can see unilateral left-sided ptosis. And you can also see meiosis and anhidrosis on his face. Diagnosis can be done with the help of CT scan, chest X-ray, biopsy, which confirms the cell type. This is an CT scan of a patient having Pancoast tumor. This is a transverse section taken at the apex level. Here on the right side, you can see there is an or in the right lung, you can see there is an opaque density which represents Pancoast tumor. Treatment: radiation, chemotherapy, which will going to shrink the tumor, and surgical removal. Here is the summary, in which diagnosis is Pancoast tumor, discovery by Dr. Henry Pancoast, location apex of the lung, compression of stellate ganglion, recurrent laryngeal nerve, and C8 and T1 root values of brachial plexus. Risk factors: tobacco and smoking. I have highlighted the smoking part in this. As we know, yesterday was 4th of February, जो कि वर्ल्ड कैंसर डे के तौर पे भी सेलिब्रेट होता है. और जब हम कैंसर की बात करते हैं तो लंग कैंसर जो है वो सबसे ज़्यादा कैंसर रिलेटेड डेथ कॉज करता है, जिसका कि मेजर रीज़न स्मोकिंग है. जैसे कि हमने अपने केस में स्टार्टिंग में भी देखा था, एक 75-year-old मेल पेशेंट है जो कि चेन स्मोकर है. तो रिस्क फैक्टर्स जो है उसमें स्मोकिंग सबसे ज़्यादा इम्पॉर्टेंट रोल प्ले करता है. डायग्नोसिस CT स्कैन एंड चेस्ट बायोप्सी, ट्रीटमेंट radiation, chemotherapy and radiotherapy. And now I would especially like to thank my friend Yamini and Yuvika. They really helped me to make this PPT and equally contributed in this presentation. Thank you so much. Thank you everyone. And I will call Vanisha Goyal to continue this presentation.
Good morning to one and all present here. This side Vanisha Goyal, presenting on the behalf of Batch D on my case was mediastinal syndrome. As the case states, a 52-year-old person, chronic smoker, presented with severe dyspnea and retrosternal chest pain in emergency. He also complained of dysphagia, dysphonia. Clinical examination revealed dilated vein around the neck and edema of the face. The radioimaging study demonstrated a soft tissue neck mass compressed the mediastinal structures. This X-ray was given to us, and these are the question tabs which were asked in the case. Which structure are being compressed in the case? Second, describe the anatomical basis for the symptoms. Third, depending on the location of the soft tissue mass and the patient's symptom, which divides the mediastinum is involved. Fourth, which structure might be involved if the mass is located in the middle lobe of the right lung. And fifth, the mediastinal widening. So let us start. When we talk about mediastinal syndrome, it is the case in which the mediastinal structures are compressed by the tumor and the group of symptoms are being observed. If we see, the mediastinal syndrome is comprised of two words, mediastinum and the syndrome. Mediastinal is the region in the chest between pleural cavities that contain the heart and the thoracic vessels, except the lung. If we see the image, we are seeing the greenish part which is representing the mediastinum, which is in between the two pleural cavities. In the next image, which is also clearly visible, in which mediastinum is in between and the two pleural cavities, which are bifurcated between visceral pleura and the parental pleura. Parental pleura is also bifurcated in mediastinal, costal, diaphragmatic and the clavicle. Next, if we talk about the boundaries of the mediastinum, it is entirely surrounded by the sternum, posteriorly by vertebral column and paravertical fascia, superiorly by thoracic inlet, inferiorly by diaphragm and laterally by the parental pleura. Now, if we come on the case, mediastinal syndrome, the compression of the structures which were involved in our case were esophagus, trachea, great vessels and the recurrent laryngeal nerve. If we come on the clinical terms which are used in our case were dyspnea, in which the compression of trachea is considered, dysphagia, in which the compression of esophagus is being taken, and dysphonia, in which recurrent laryngeal nerve is compressed. In our case, dilated neck veins and swelling of the face was also seen. These are the images in which we can see dysphagia in the upper one, and in the lower one dyspnea, in which it is compression of the trachea which led to difficulty in the breathing. Next, if we ask to mention which division was compressed. So in our case, superior mediastinum was compressed, as mediastinal divides superiorly and inferiorly. Superiorly, if we see, it is the portion above the sternal angle, and inferior part is below the sternal angle. Inferior is bifurcated again in anterior mediastinum, medial mediastinum and the posterior mediastinum. Next, if we talk about the middle lobe lung mass complications, in which mainly superior vena cava is compressed, due to which it is also known as superior vena cava syndrome. In nerves, if we come to phrenic nerve, due to which diaphragmatic paralysis may be occur, because phrenic nerve comprises it. Then in last, we were asked to describe about the mediasternal widening. What is mediasternal widening? It's mean only the widening in the region of the mediasternum. That X-ray mainly comprise that the widening is there in the mediasternum, and the main cause of the mediasternal widening is enlargement of the lymphatic nodes and also hemorrhages of the blood vessels. It can also be diagnosed by the CT scans, X-rays, MRIs, which through which we can identify the specific structures involved in the mediastinal widening. Mediastinal widening can also be calculated by the cardiothoracic ratio, in which A plus B by C ratio is taken. In cardiomegaly, is also the cardiothoracic ratio is increased from the normal one. So there is a widening in the mediastinal, and hence it is known as mediastinal widening. So this is all from my side, and thank you so much, ma'am, for cooperating with me, and thank you for appreciating that Prabjot ma'am and Sakshi ma'am helped me so much for the PPT, as I was not feeling well in the previous days also. So thank you.